Assalamu alaikum. Welcome to our exciting session arranged by Basic Dental School Bond with a very interesting and important topic, oral cancer and reconstructive surgery. Our honorable speaker is Dr. Abdullah Al Masood Sir, FCPS, PDS, Advanced Training on Microvascular Surgery, Orthodontic Surgery and Implantology, Assistant Professor, Oral and Maxillofacial Surgery, Dhaka Dental College. Our respected moderator is Dr. Munjuri Mahmood Sir, FCPS PDS, Assistant Professor, Oral and Maxillofacial Surgery, Dental Unit, Chittagong Medical College. Thanks both of you for allotting time for us, sir. Now I would
Thank
like
you.
to request Dr. Munjuri Mahmood Sir for conducting this session.
Thank you very much, Muntahina, and thanks to Basic Dental School. And Assalamu alaikum, ladies and gentlemen. We'd like to pay our gratitude to Basic Dental School Bond for arranging such programs for young dental surgeons as well as the students and other practitioners of dentistry in our country as well as abroad. Oral cancer and reconstruction of the defect created by ablative surgery is an important topic in our daily practice as well as our maxillofacial surgery practice. And today we have Dr. Abdullah Al Masood, who is currently working as an assistant professor in the Department of Oral and Maxillofacial Surgery of Dhaka Dental College. And he is a graduate from Dhaka Dental College, as well as he has got his HCPS training in Dhaka Dental College, and he has passed his HCPS degree in the year 2010, and he gathered enormous training from various institutes of the world, different corners of the world, regarding the cancer surgery and reconstruction, especially microvascular surgery. And he is, to me, he is an accomplished surgeon, and he works in almost every aspect of oral and maxillofacial surgery, like cancer surgery, reconstructive surgery, orthodontic surgery is his another specialty. Cleft surgery, he has done remarkably well in cleft surgery as well. And nowadays he is doing implants, which is not so much highlighted in his practice, I think. And you will be delighted with his presentation, I think. And everybody is requested to be attentive, and I think today's session will be informative and it will be beneficial for all. I think the presentation will cover various basic aspects of oral cancer, its preventive approaches, and detection by the dental surgeons in the private chamber, as well as in hospital and primary clinical settings, and the reconstructive options of oral cancer and other treatment options will be discussed subsequently. Now I would like to request Dr. Abdullah Al Masood, Assistant Professor of Oral and Maxillofacial Surgery, Dhaka Dental College, to begin his today's presentation. Thank you very much.
Thank you very much, Dr. Munjuri Mahmood, my ex-colleague. You introduced me very nicely, and I'm very much delighted to be here with Basic Dental School. And thank you very much, the Basic Dental School, for arranging such a good session. So basically, there are lots of people suffering in oral cancer in our country. And the purpose of this presentation is mainly, I will say that I want to introduce you, that is, what is our hope, what can we do for the cancer patient. As we know, in case of cancer, we have to resect very big tissue, and lots of parts of the body of the oral tissue such as the mandible, maxilla, tongue. All of these are very functional tissues. So our aim should be a functional reconstruction, that is patient can back to the normal life again, which will decrease his stress and burden also, and he will be very much confident for the further life. So we are working in this field after completion of our postgraduate degree and working in this field. Monju already introduced me very nicely. I don't know how much I can do this, but we all are trying to do better. And Monju also, once upon a time, we worked together in Dhaka Dental College, and we had a great memory. So I think I can share my screen. Uh, so in oral cancer, we know people wants actually a very good result and a very good aesthetic outcome, but we have to understand that never we should compromise with the resection. Can you see my screen? Can you see my PowerPoint presentation, please, Manjur?
Yeah, yeah, it is visible. You can start
Okay,
now.
okay. So, in case of cancer patient, they always wants a good face. They wants a very good function. But all of our surgeons should know that we should not compromise the excision. So, if we compromise the excision, then the cancer will recur. And we know that in case of in the world, the oral cancer is now the sixth most common cancer. But in Bangladesh, there are very few data, and some data says in Bangladesh, the lip and oral cavity cancer is the second most common. And few data says the death for oral cancer in case of male is the second most common cancer in Bangladesh. And and there are lots of factors associated for this subcontinent. We know we have similar habit in Bangladesh, Pakistan, India, Sri Lanka. We the people are have a similar habit. There is betel quid, pan, jorda, gutka. There are lots of form of tobacco materials are they are using. So the prevalence is same, and the commonest sites are the lip, tongue, GB sulcus, that is gingival sulcus, and we can see there's some fungatic lesion, which are although very late. And in case of oral cancer, when we see there is a lesion in the oral cavity, which is granular in appearance, exophytic growth, the base is indurated, and very exophytic growth, which is not healed. Initially, it is painless. So we can suspect that it may be a cancer. So you can see the screen, the lip cancer. This patient usually used to take the ghoul for 25 years. And he used to take the ghoul in the lower lip. So there is a cancer in the lower lip. You can see in the middle of the picture. And some picture are also here in the floor of the mouth. There is an ulcerative lesion. Initially, it is painless. Patient ignore it, and they come to the doctor after late presentation. In case of tongue, there is a maybe from sharp tooth or maybe for lots of habit. So you can see the immobile tongue, and there is a ulceration in the lateral border of the left lateral border of the tongue. In case of palate, there is a small growth may occur from the salivary gland tumor also. And how we can diagnose the cancer. In case of cancer, we can take the history, that is how long it happens, how frequently it is growing, and then we do the clinical examination. Then we go for the specific investigations, such as the incisional biopsy, followed by histopathology or FNAC, and others, the CT scan, MRI. Then we can diagnose the cases. So after diagnosis, though, so what is the main treatment? So there are lots of treatment in oral cancer. That is surgery, radiotherapy, chemotherapy, targeted palliative therapy. But when the lesion is accessed with a negative margin, that is the margin you can fully excise the lesion, then surgery is the first option. Then you can go for the radiotherapy or chemoradiation combined with the radiotherapy, radiotherapy plus chemotherapy. And in case of surgical treatment, I want to share a few slides according to the site of the lesion. Uh, we know in lip cancer, we can excise the lip, we can do the surgery, then we can reconstruct it by the local flap, such as Abbey flap, or sometimes very small lesion, we can do the local closure, and we can do the carapenzic flap, a slender flap. But in case of big lesion, then we have to reconstruct the lip by microvascular free flap. So here you can see a patient of cancer in the lower lip. There is a dotted margin is the indurated margin, and 1 centimeter clear margin was taken, and that's why there is a big excised area. So how can we reconstruct it? In case of older people, we can do the reconstruction more than half or two-thirds of the lip we can reconstruct by the carapenzic flap. Here you can see the last picture says the comparison with the previous picture. The aesthetics is ultimately a little bit same, and oral sphincteric action is good. And you can also reconstruct it by according to the defect of the lesion by Abbey slender, McGregor flap, etc. Here is a case of GB sulcus cancer which involved the lip. Nearly half of the lip is involved and indurated. So my plan is totally three-dimensional excision. That is part of the mandible as well as the half of the lip is excised, and here the marking is for the neck dissection. And you can see the excised tissue with teeth, marginal mandibulectomy, a lip, and the lesion. So defect is like this, and which can be, as we know, the oral tissue is more pliable, lip is more pliable tissue, thin tissue. So we should choose the tissue as like as the lip. So we choose the radial forearm free flap, as it is a fascial cutaneous flap, and it will give a pliability, and so it is a very good thing for reconstruction of the lip. Here the lip and cheek part is reconstructed, and this is the picture after a few years. And one important thing is that we have lost this patient 3.5 years later because he had also used the goal, and after operation he didn't leave his bad habit. That's why any another cancer was recurrence in the maxilla, and he refused to the second surgery. That's why we lost this patient about 3.5 years. And this is the patient who already took 25 years. They used to took the ghoul, and there is a squamous cell carcinoma in the lip. So we have done very drastic surgery. We want more and more life. That's why we took en bloc resection of the total near total lower lip as well as the marginal mandibulectomy, as it is very close to the GV sulcus, and so we did the marginal mandibulectomy also, and this we have done the bilateral neck dissection. As we know, the cancer spreads in the lymphatic channel in case of squamous cell carcinoma. That's why we have to do the neck dissection, and it is a total lower lip, near about total lower lip is as it is involved. So we have to do the bilateral neck dissection, and this is the immediate after reconstruction by the radial forearm free flap, which was taken from the right hand. Usually we used to take from the left hand, but unfortunately the sister of this hospital, she used to do the cannulation in the left hand. That's why I have to choose the right hand. And this is the result after radiotherapy. We maximum radiologist or the oncologist or any other person can guess that there is a bad effect after radiotherapy in the free flap. Yes, you can see that there is no flap necrosis or nothing after radiotherapy in the microvascular free flap. So it's another case of GB sulcus cancer, which is involved in the angle of the mouth, and so we have to exercise for to get the free margin. We have to exercise the part of the lip, upper and lower lip also. So it's a big challenge to make the commissure. So this is the defect after neck dextration and also the excision. And it's a special design of the radial forearm free flap. Here you can see in the right side of the left side of the picture, radial forearm flap is here designed in a special way to make the both upper and lower part of the lip. And that is the outcome, the frontal level. And main outcome is the basically main outcome is the opening of the mouth. So opening in the mouth is very important, and here we can see that the opening is very good enough. So in case of only cheek cancer, we can reconstruct it very various way. We can use the local flap, we can use the local regional flap, and also we can use the uh, microvascular flap. Here it's the rhomboid flap is used. It's a fascicutaneous flap, and in the inner side, the uh, here buccal pad of fat is used. So it is the result immediate after operation. And this is a few years back about it is immediate after operation, but patient is live now. It's about this operation was done about 7 years ago. And you can see there is the limitations of mouth opening. So in case of local and or local regional flap, there is some limitations for function. So here you can see there is a limitations in mouth opening. Basically, in case of reconstruction, our goal is to make it very functional. So here, if we can give the radial forearm flap in the newer technique, then I think the result will be much better. So it's another case of squamous cell carcinoma in the cheek, right cheek, and through and through excision was done, and it is also done with partial mandibulectomy and as well as the type 1 maxillectomy. And it is also reconstructed by the radial forearm free flap, and our outcome is good. She is about 4.5 years running. She is also good and alive now. And in middle portion, you can see that there is a blackish color of the skin during the radiotherapy. So it may happen, and it will be then the color will change and back to the normal after few months, couple of months. So after giving the again and again, I want to see after giving the radiotherapy, there is usually no bad effect in the free flap. So that is the result after 4 years, and patient is quite good. She used to do the regular follow-up with me, and she's quite fine. It's another case of GB sulcus cancer, and which is involved the cheek also, and cheek skin is involved. It's a neck dissection, and through and through excision was done. And here we have done uh, uh, the ALT flap with nerve transfer, because day by day we have to improve the function. Here you see there is a lower the facial branch, lower lip branch. It is preserved and marked out, and also the upper nerve also, and the main trunk also. And we took the nerve from the anterolateral thigh flap as well as the muscle and nerve, and then muscle is taken and the flap is taken, and the from this anterolateral thigh flap the nerve is also taken for the nerve coaptation. Here you can see. So for the better and better function, we are starting now the nerve graft also. So that is the immediate result. And in case of nerve grafting, we have to wait 7 to 9 months for the result. And in case of GB sulcus, we can do the local flaps, that is nasolabial flap. We can do the reconstruction by the pectoralis major flap. In case of small lesion, we can do also submental island flap. And in case of microvascular surgery, we can do radial forearm free flap, anterolateral thigh flap, and fibula flap. And in tongue cancer, in case of tongue, we want mainly the function. And the tongue is a very mobile organ and helps in speech and deglutition. So it is very important if we can restore almost 50% of the function, then a patient can take food, patient can speak well. So in case of tongue cancer, we can do the local flap, submental island flap, nasolabial flap, even infrahyoid flap. And in case of large excisions, we can do the pectoralis major flap. And for tongue, the small amount of tongue excised area we can reconstruct by the radial forearm free flap. But if we need the bulk and more tissue, then we have to use the anterolateral thigh flap or rectus abdominis flap. Here is a actually excised tongue cancer because this patient was previously irradiated. So we prefer hemiglossectomy and reconstructed by the pectoralis major myocutaneous flap. This is the result after 1 year. And it's a partial glossectomy was done. Here you can see the lesion as well as the marking. And flap is taken from the radial forearm, here 9.5 into 7.5 centimeter. One is for use for tip and another for the bulk and lateral area. So this is the ventral surface, and the posterior part is reconstructed well, and you can see the tongue movement. The tip function is good. Tip can touch the palate, and patient can move his tongue very well. And that's why we choose in case of partial or hemiglossectomy the radial forearm free flap, because it is very much pliable and adequate amount you can took with it. So the result will be very good. Because by locoregional flap, you can give good result with the submental island flap, but as it is from the submental region, sometimes we cannot use it for the oncologic perspective, because there is some positive node in the level 1A. So it's better to use the radial forearm free flap for good aesthetic and functional outcome. But if we need near total glossectomy or extended hemiglossectomy, then we should need good bulk. And it's a case of large oral tongue cancer, which also involve which invade the median septum and the opposite side. So my plan is extended hemiglossectomy or near total glossectomy. And it was reconstructed by the anterolateral thigh flap, and patient doing excellent 2.5 years, and he is good. So now come to the mandible. The cancer usually not involved in a single area. We know in case of GB sulcus, mandible is involved, but some solely mandible cancer is very rare. So if we want to reconstruct the jaw, so we can think about the microvascular free flap by fibula. But if you not wants to reconstruct the jaw by bone-like tissue, then you can use the reconstruction plate, as well as it wrapped by the PM flap. Or there are some school they are using reconstruction plate with the anterolateral thigh flap. They wrap the plate by the anterolateral thigh flap. So we can do the mandible both way. It is depends on the institution to institution and the facilities. So in case of bone-like tissue, fibula is the best, and we can use the scapula or DCI also. That is deep circumflex iliac artery based. Here it's a, case of mandible, and as well as the cancer affected the skin. So 7 by 4 centimeter skin is excised along with the hemimandibulectomy. And here you can see the marginal mandibular nerve trying to preserve it. Actually, we can show the marginal mandibular nerve, and you can see the hemimandibulectomy specimen with the all muscles of mastications is here, and it is very reconstructed by the fibula. Fibula is taken from the left leg, and it is the skin is divided into two parts according to the perforator. For one, as it is a through and through defect, one is for the posterior, one is for the intraoral, and another one is the cheek, and that is the immediate result after reconstruction. And here you can see in the OPG film, the mandible is more or less very good shape was done, and there is no midline displacement here. As we know, we have no 3D software technology to use them for proper bending and everything, so we can do the in freehand. So here the midline shift is minimum and zero, and excellent outcome. She it's about 8 or 9 months she took the radiotherapy and doing good. It's another case of mandibular cancer as well as the GB sulcus, and through and through skin defect was reconstructed by the fibula, and you can see the fibular skin is already divided into two parts according to the perforator. One is for the inner side and one is in the outer side. So very good reconstruction after a few days after immediate after the surgery, and he is good, doing good. 1 year has gone. And again, we can talk about the GB sulcus and mandible. It's a big cancer, T4, and stage 4 also. So the big tissue is needed for reconstruction. Here is a huge, extensive lesion which is excised, largest cheek skin and mandible and the part of the maxilla, and it is reconstructed by the anterolateral. When we need a large soft tissue, anterolateral thigh flap is our choice, because we can took about 12 by 35 centimeter tissue from the anterolateral thigh flap. And this is 4.5 years later. She is doing good. She is still alive and doing very good and without recurrence of the disease. So fact is that in case of this stage 4 lesions, so we can say that, oh no, that is not the surgical issues, so issues of the radiotherapy or chemotherapy. So look, if you do a good job, if you do the reconstruction, if you do take a margin free clearance, so then the result will be very good. It's another lesion of the GB sulcus and mandible. It is already reconstructed by the anterolateral thigh flap. This is the defect, and 15 by 6 centimeter anterolateral thigh flap was taken from the left thigh, and this is immediate after reconstruction, and this is 5 years later. Patient is doing good, excellent. There is no recurrence, and patient is doing good. She comes to me with regular follow-up. So this advanced case, there is I think, yes, of course there is a, if you get a very if we get a margin free clearance, and if you can reconstruct it very well. So the free flap is the answer, and there are some cancer in the ITF from the lower jaw. Say it's a, and in ITF it can go from the upper jaw also. It's a case of maxillary carcinoma where the node is positive, as well as we have to do the maxillectomy. There is a large hole. So the anterolateral thigh flap you can use it as a chimeric flap based on the perforator. One perforator, one skin pedicle is for the maxillary seal and another for the neck. This is the result. Unfortunately, he's doing. Oh no! Fortunately, he is doing very good, and 3 years is gone. And it's a very advanced lesion, T4V lesion, and we cannot see the lesion in direct vision because there is a trismus, and there is lots of comorbidity. He had hypothyroid, he is epileptic, and also he had sodium depletion. He had sodium depletion. So you can see there is a lots of comorbidity, and we did the operation. We did a compartmental resection, three-dimensional resection, and there is the reconstruction by the anterolateral thigh flap, and 3 and 5 years is gone. He also took the radiotherapy, and he's doing good. He's very fine and comes to regular follow-up. His 3 and 5 years has gone. And it's another case of GP sulcus cancer, involved the cheek also, and also the trismus. So we have done the compartmental resection up to the skull base, and lower and hemimandibulectomy and partial maxillectomy also done. It's a specimen, resected specimen, and huge large anterolateral thigh flap is needed for cover of this big defect. And it is also divided into two parts according to the presence of the perforator. One is for the inner lining, one is for the outer lining, and very excellent result. Already 1 year and 8 months has gone. Yesterday he came to me for the follow-up. You can see the skin is epithelialized and changed into mucosal color, and also the donor side is very healed very good after split thickness skin graft. And this is the result, lateral view and frontal view. You can appreciate, I think, this kind of operation and this kind of surgery. And patient is very hopeful now, and he told me that he wants to leave the theater without operation, but now he is very good without recurrence. There is 1 year and 8 months has gone. Let's see the future. I think it will be fine. So let's take a break and have a cup of coffee. uh, Okay, so now come to the maxillary carcinoma. In case of maxillary carcinoma, we have to excise the maxilla. In case in Brown's classification, type 1, 2, 3, 4. So according to the defect, we have to choose the flap. If the defect is very small, we can use the masseter flap, we can use the palatal island flap, we can use the nasolabial flap, we can use the temporalis flap, which is very versatile. And in case of microvascular flap, we can use the radial forearm free flap, anterolateral thigh flap, and also we can use the fibula if we can we want to do a good maxillary reconstruction by bone, or if you want to rehabilitate the patient with the implant, then we can use the fibula also. So let's see a few cases. It's a case of adenoid cystic carcinoma in the in the right side of the maxilla. Here level 2 maxillectomy was done, and it was reconstructed by the masseter flap, and that is the result. Benefit of this reconstruction is that she needs no obturator, no regurgitation of the fluid in the nasal cavity, and patient is very fine, and she is doing very fine. 6 years has gone. She is doing very fine. She is alive and doing very fine. So it's another case of mucoepidermoid carcinoma in the maxilla, which in case of CT scan, we can see that it is very big, and it was high-grade mucoepidermoid carcinoma. My plan is maxillectomy, then the defect was reconstructed by the temporalis flap, and here is reconstruction, and that is after operation, and 9 years has gone. Patient received the radiotherapy also, and he is doing fantastic, is free of disease, and very confident now. Look, if we don't reconstruct the maxilla will looks like this, and patient have to wear the obturator, and always we took the fluid type of fluid, so there is always regurgitation in the nose. If you can reconstruct the maxilla with the flap, the result will be like this. So there is a very the benefit of this reconstruction is excellent and very good, and patient's confidence is more. So here is the outcome, and 9 years is gone. It's good now, and it's another case of post squamous cell carcinoma in the posterior maxilla, and total compartmental resection done, and it was ITF was cleared and anterolateral thigh flap used, and patient is doing good for the 3 years. Uh, Now, come to the cancer in the floor of the mouth. We know the floor of the mouth, there is also tongue is involved, mandible is involved. Okay, so it may involve the tongue, it may involve the mandible. So, in case of floor of the mouth cancer, we should for the function we can choose the fibula, radial forearm free flap, or ALT flap. Even you can use the PM flap, pectoralis major myocutaneous flap. And it's a case of squamous cell carcinoma in the floor of the mouth. And here the compartmental resection done, three-dimensional excision with the floor tissue from the floor of the mouth, as well as the suprahyoid muscle, and bilateral neck dissection was done. There is the very good reconstruction done by the fibula. You can see the fibula in the OPG X-ray with the reconstruction plate, as well as the fibula skin is now turned into the oral mucosa. And patient did not took radiotherapy, and he is doing very good. 3 years already passed, and I'm quite happy with the resection, and patient is doing good. Here you can compare the picture, the preoperative and postoperative picture almost same. There is no visible scar, and her appearance is good, and it keeps him confident. And patient is doing good. 3.5 years already gone, and he's doing good. So again, in the retromolar trigon and ITF, it's a case of cancer in the retromolar trigon and involved the ITF. She took radiotherapy previously 1 years ago. Then the lesion is almost the same in this area, and we did the chimeric anterolateral thigh flap muscle for the ITF pack and the skin for the oral lining. Here is the 4 years later, patient doing excellent. And in case of there are some complex reconstruction we have to do. Sometimes there is a lesion which involve the lots of anatomical areas such as soft palate, alveolus, RMT, and tongue. It's a case where the soft palate is involved, retromolar trigon is involved, the inner surface of the upper lip is involved, and the tongue is involved. So lots of anatomical parts are involved. So here is the excision and neck dissection. Mandibulotomy was done, and the excision of the lesion, and it was nicely reconstructed by the radial forearm free flap, and a couple of weeks after the reconstruction. And it's a very recent case, so I cannot give you the survival data. And there are some very advanced cases sometimes when we need double flap, such as this case. There is a very late presentation, but in the lower jaw it is very big, and lots of sinus present also. Here you can see the indurated body, indurated part, and sinus present. Yes, big tissue should excise, and this is after excision. Mandible, two-third mandible has gone, and floor of the mouth and everything. Bilateral neck dissection done. Big skin need to reconstruct this tissue. Here is the excised tissue, and we choose the mandible. We choose for the mandible. We choose the fibula, and fibular skin is used in the intraoral lining. And for the extraoral line, extraoral tissue, big size of anterolateral thigh flap was used, and patient is doing good now. Hope, let's see the outcome, because it is done 9 months ago. So we have to see the survivability. So here is the in OPG X-ray. You can see the fibula, and this is a couple of weeks later after the operation. So, in conclusion, I want to say that in case of oral cancer, it's a major problem and large burden for the advanced cases. And in advanced cases, multidisciplinary approach is needed, and single modality treatment for early stage and combined modality for advanced stage disease. And compartmental resection have promising result, and salvage for advanced disease has satisfactory outcomes. And thank you very much, and thank you everybody for your patience hearing. And thanks Basic Dental School. I think the now turn Dr. Monjur and wait for the question and answer session. Thank you.
Thank you very much. Thank you very much, Dr. Abdullah Al Masood, for your brilliant presentation. And it was very informative regarding the reconstructive options in different anatomical regions of oral cavity. And I think our trainee doctors as well as the junior dental surgeons are benefited well from this type of presentation. And in my comment, I'd like to I'd like to throw some questions from the audience, and some questions are asked like that. Mr. Azizur Rahman, he is saying, Assalamu alaikum to all of you, sir. Wa alaikum assalam. Shoaib, hope we will learn many information from this presentation. Jinuk said, Assalamu alaikum. Azizur Rahman said, Assalamu alaikum, sir. I have a question. Why doctors recommended orthodontic surgery after completion of growth part? Why they don't recommend orthodontic surgery before completion of growth part? This is a question from orthodontic surgery. I think Dr. Masood will discuss it later, or we can discuss it.
Although the session
So
is
it is.
Thank you. As because the people know that I'm only the orthodontic surgeon, that's why they ask the question. Okay, no problem. Because orthodontic surgery we used to do after the completion of the growth, but before completion of the growth, if you do the correct orthodontic surgery, then if we don't know how much the growth speed is, if we select a few millimeter advancement, then again the growth will happen. Then there is be that will be another, again there will be a deformity. That's why we wants to do the orthodontic surgery after completion of the growth. But there are some times there is the psychological issue is important rather than the growth completion issue, growth issue. Say one child could not go to the school for bullying or something. On that time there is a mental pressure. On that cases you can do the orthodontic surgery in growing stage, but you have to discuss with his or her parents that she or he may need again jaw corrective surgery. On that time you can grow in the growth period.
One of your childhood friend, I think, Mr. Hawk Bepari, is very proud of you, and he said that you can go on. And
thank you, Mr. Hawk.
Rafi Kazi Hussain says that I am surprised that our Bangladeshi dentists are so quality full and experienced as like Western countries. Thank you. And he also wants to know how can the general people be saved from oral cancer. I think he wants to know about preventive approaches.
First of all, in case of general people, everybody should go for checkup regularly. And if there is a ulcer which is standing for 3 or more weeks and which is growing rapidly, so they should check the specialist and do for biopsy. Then you can do the early detection, and if you do the early detection, then the result will be more. But in case of oral cancer, I would like to say, if you change your behavior, if you change your lifestyle, I think it will be better. That is, if you avoid pan, jarda, supari, gutka, everything, then I think maximum percentage of oral cancer you can quite be you can be sure that you will be free, you will be happy and free without cancer. But there are some cancer which is genetically some predisposing factor. In that cases we cannot do anything, but there is the cancer which is associated with some bad habit, especially oral cancer, oral squamous cell carcinoma. If we leave our bad habit, then we can take free and for regular checkup, I think.
Yes, I can also add something to you that most of the people in our country are unaware of their oral cavity, and
Yes.
they often seek treatment. They often seek treatment from quacks and
Yes.
village doctors for their problems in the oral cavity. And I would like to recommend and request all the general people to go to a qualified dental surgeon who are having at least BDS degree and having BMDC registration. And
Yes.
everybody should seek dental treatment and oral checkup after every 6 months to a qualified dental surgeon who have at least a BDS degree having BMDC registration. And that is the key. And our dental surgeons can detect uh, oral cancerous lesions in a very early stage. If they are vigilant enough and they look for it, like cancer screening can be done in dental practices regularly. And after every patient who are elderly having some habits, we can also counsel the patient to refrain from their bad habits to further prevention of oral cancer, as well as we can detect the cancerous lesion very early. And one of the reasons of our failure or advanced disease is every patient, almost most of the patients come to the maxillofacial surgeons in a very late stage, where the ablative surgery and large reconstruction has to be done. I think everybody has a role for the prevention and early detection of oral cancer.
Exactly.
And
Exactly.
another question is, yes, another question is from Shoaib. When will you go for radiotherapy or chemotherapy rather than surgery?
Actually, for a small lesion, that is T1 lesion, you can go single modality treatment, which is a textbook already, which textbook says that. But in our country, when the lesion is inoperable, then they have to go for chemoradiation. Otherwise, surgery is first, then go for chemoradiation or only radiation therapy. But in case of oral cancer, when we do the neck dissection and find the neck is positive, then we suggest chemoradiation, concurrent chemoradiation.
Yes, chemoradiation has got three uses in case of oral cancer, I think. One is for therapeutic radiotherapy and chemotherapy in case of early cancer, where T1 and T2, it can be treated either by surgery or by radiotherapy. Both of them can be employed in T1 and T2 cases. And in case of T4B or large lesions, it can be treated by neoadjuvant chemotherapy, which role is debatable. Neoadjuvant chemotherapy followed by surgery, followed by concurrent chemoradiation, but the role is debatable. And another role of chemotherapy is palliative chemoradiation, when there is no scope of surgery, either due to the lesion or due to the patient factors such as very moribund patient having many systemic diseases where surgery has no scope, there is no scope of surgery, then we can send the patient for palliative radio and chemotherapy.
Yes.
And another question is from Jiaul Arifin Abir. He wants to know about composite and en bloc resection. En bloc resection.
Composite and en bloc. En
Yes.
bloc means actually in case of if you if you excise the cancer in a block, that is whole cancer tissue, if you take it out in a block with a negative margin, that is en bloc. In case of mandible, if the lesion is small, then if we do the segmental or sectional resection, that is also en bloc resection. So another question is
This was the question. En bloc and composite resection. What is
composite
resection?
resection means when the lesion is involved in the various tissue, then you have to exercise the bony tissue, muscle, skin, or various part. That is composite resection also. That is not in a single organ.
Yes. If it involves only the mucosa or only the skin, it is simple excision. But
Yes,
in
yes.
case of composite excision, it must encompass mucosa, muscle, bone.
Yes.
This is,
Very
I think, is composite. And another question from Dipayan Dipu. He said that it is a wonderful presentation, sir. Thank you so much. After doing neck dissection, where facial vessels are encountered, what is your opinion to do any local flap to reconstruct lip?
Sorry again.
After doing neck dissection, where facial vessels are encountered, what is your opinion to do any local flap to reconstruct it? I think he wants to know that when we clip the facial vessels, facial artery and vein, what are the other options we can use during local reconstruction of lip by local flap?
Okay, so
I think sometimes we are encountering facial artery and vein in the level 1B dissection, and we have clipped the facial artery and vein. So we cannot use the nasolabial flap, nasolabial island flap, and submental island flap.
Yes,
Then what are the options?
So in this case, for local flap, you can use the forehead flap. In locoregional flap, you can use the PM flap, and sometimes you can use the sternocleidomastoid. Although we use very rare, you can use the infrahyoid flap. Yes.
Yes. Another option can be supraclavicular flap.
Yes, supraclavicular. But in case of doing supraclavicular flap, your neck dissection, you have to very careful during neck dissection, because you could not hamper the transverse cervical artery. So our perforator comes from the transverse cervical artery.
Yes. Another question from Shahadul Islam. Patients with comorbidities such as diabetes mellitus, hypertension, and cerebrovascular disease, is it possible for these patients to microvascular free flap on perspective of mortality?
First of all, diabetes is not the factor. Diabetes you can control by the drug. And another one is hypertension. You can also control it, but the other cerebrovascular disease, that is peripheral vascular disease or other vascular disease, then and if the patient has lots of comorbidity who cannot withstand the long-standing surgery, in that case you cannot do the microvascular surgery. You can use the locoregional flap. You can use the pectoralis major flap or thoracodorsal artery based flap, or etc. etc.
Thank you. Another question from Mashukur Rahman. what will be the surgical approach in case of floor of the mouth and base of the tongue cancer?
In case of floor of the mouth, the approach is very fine. You can do the bilateral. If you do the bilateral neck dissection, then you can give the apron incision or utility incision. Then you can go the up to the mandible. Then you can cut the mandible with floor of the mouth. The thing is easy. But in case of tongue-based cancer, at first you should have to diagnose either it is resectable or not. If it is resectable, or if you can resect the total glossectomy, then two things you have to do. At first, you have to do the peg for the patient, that is percutaneous endoscopic gastrostomy for the feeding of the patient to maintain his nutrition balance. Second one is you have to do sometimes the laryngectomy also, and you have to make the oral cavity for only for the feeding, and for the this respiration you have to do the tracheostomy here, and that is the protocol, and then you can exit. Because tongue-based cancer, here is the epiglottis is loss is control. In case of big cancer, then there is aspiration, and for aspiration patient may die. So in that case you have to consider this. And but in tongue-based cancer, you can go pull through technique, you can mandibulotomy technique, you can go the angle osteotomy technique, you can go lots of way.
Yes. In case of base of the tongue and floor of the mouth cancer, it is very much important to have disease-free survival as well as functional
Yes.
outcome. That is,
Yes.
patient swallowing function is very much hampered by this.
That's why you have
operation.
yes, your plan
That's why PEG tube must be inserted beforehand. PEG
Yes.
tube, percutaneous endoscopic gastrostomy, as well as permanent tracheostomy sometimes has to be done,
yes,
which you have mentioned earlier. And I think nutritional support is very important for every cancer patient, and we have to rethink our strategy, and we should discuss with the nutritionist beforehand. And multidisciplinary team, in a multidisciplinary team, we involving the care of cancer patients, we must have a nutritionist, a physiotherapist, and a clinical psychologist also, I think, during the treatment planning and management stages. And one of your patients said that patient cannot quit his or her bad habits. That's why another cancer in the second site has developed. And I think NCCN guideline is addressing this type of problems correctly. They employed a psychologist in the cancer care team so that they can counsel the patient for depressive illness after surgical care, as well as they are helping the patient to quit their bad habits regularly, bad habits. And I think we should also consider this type of multidisciplinary care. Another question from Shafiul Alam. He says, thank you, sir, for wonderful presentation. Which flap is best option for reconstruction of cancer involving the tongue and floor of the mouth? I think you have discussed it earlier. You can discuss it again.
I want to say, in case of floor of the mouth and tongue cancer, first of all, you have to decide you have to detect the disease extension. Then you have to take the decision of amount of excision, which tissue is lost. Then you decide the flap. If the volume is if the volume is less, then you can use the radial forearm free flap because it is pliable, you can move it. But if you need the very good bulk, then the option is anterolateral thigh flap. And also you can use the fibula of your skin.
Yes.
For floor of the mouth if you do the mandible.
Mashukur Rahman has another question. He wants to know how marginal mandibular nerve can be preserved during neck dissection.
How? Okay, it's very important. The marginal mandibular nerve is sandwiched between the uh, submandibular gland and the fascia. So you have to go 2 finger breadth at least from the lower border of the mandible, and you have to stay in the line down to the submandibular gland. Then you raise the flap. You raise the fascia over the submandibular gland. That's why you can preserve the marginal mandibular. Another very important tips is marginal mandibular usually in case of external jugular vein, in front of the external jugular vein, medial to the external jugular vein, marginal mandibular usually appear. So if you mark this point that okay, this is an external jugular vein, then you should be very careful in the medial side of the external jugular vein. Then in this anatomical landmark, you can unwrap the submandibular gland with the fascia. Then you can prevent the marginal mandible.
Another thing is sometimes in case of lower gingival sulcus cancer, cancer involving the lower gingival sulcus, and these patients are having some prefascial lymph nodes, which can involve the marginal mandibular nerve
Yes,
area.
yes, yes.
In
Here
that
is
case,
the
it will be very difficult to preserve
yes,
the
here is
nerve.
the facial artery, facial vessel, facial vein and artery, and there is the cross the marginal mandibular nerve, and here is the prefascial node. So it is very
Yes,
tricky.
yes. And another question from Trimatri Krubel. Thanks for informative presentation, Masud sir. Sir, can you shortly brief about the indication of segmental mandibulectomy and marginal mandibulectomy? If any large lesion in lower gingivovascular sulcus but not involving the cortex in CT scan, then what will we do, marginal or segmental? If any lesion involves only the alveolar bone causing mobility of tooth, what will we do?
In case of GB sulcus tumor, which is only touch the mandible, not erode the cortex, in that case you can do the marginal mandibulectomy. Okay, the next question is the alveolar involve the alveolar bone. If it is already involved the alveolar bone, that is it involved the deepest part. So in that case, you have to choose the segmental mandibulectomy, not the question of
Yes.
marginal mandibulectomy.
Yes.
And
Also, the lesion involving the edentulous mandible. If the
yes, yes,
lesion is abating the edentulous mandible, then there is no
yes,
scope for marginal mandibulectomy.
yes,
Another thing we should also consider that in case of marginal mandibulectomy, we must preserve at least 1 centimeter of bone in the lower border.
in the lower
If the
body.
lesion is approaching the lower border, and we cannot preserve at least 10 of bone, healthy bone in the lower border, then we should not do marginal mandibulectomy, because
Yes, for
anything less than 10 millimeter, it will cause fracture, pathological fracture later on after surgery or after radiotherapy, I think.
yes, and one thing is important. If you wants to see the invasion, then we have to write down in our pad that we want oblique reformation of the mandible. That's why we
Yes,
can see
in
the
CT scan, oblique
can
reformation tells us more about the mandibular invasion.
invasion.
Yes, Rano Hassan Bhai, he says that very much informative discussion. Thanks to both of you. Thank you, Bhaiya,
Thank you,
for
Rano.
your question and comments. Mumtahina says, very informative session. Shahadul Islam, again, thank you, sir. I have another question. What is salvage surgery?
Salvage surgery means we have resected the tumor, but we don't hope a good outcome. That is, we can less the burden of the patient. There is some fungating lesion and everything. We remove this, but patient didn't have some fungation for a few days or few weeks or few months. but we cannot take the negative margin, and that is the salvage surgery.
Okay. And Mustafizur Rahman Mamun says, great session.
Thank
Rano
you.
Bhai wants to know about treatment of T4B lesion.
In case of T4B, T4B is the say if it is high ITF, then we have to see either the foramen oval is enlarged or not. If it is enlarged, then it is inoperable. If it is foramen oval is normal, then you can operate, and that is also, I think, it's a palliative surgery. Then go for chemoradiation.
Yes, T4B lesions are debatable issue. In every
Yes.
cancer conference, there is a debate regarding the management of T4B lesions, and some centers do not suggest surgery in case of T4B, and some centers like Moni Abraham Group has divided the T4B lesions into upper compartment and lower compartment.
And this
Lower ITF
is
and upper ITF at the level of coronoid process. Where the lesion is above the coronoid process and sigmoid notch, the lesions are called inoperable, and the lesions below the sigmoid notch, they call it operable. And in case of some centers, they prefer to use neoadjuvant chemotherapy to downstage the tumor and then do the surgery in case of T4B lesion sometimes.
Yes.
Arifur Rahman says, great discussion. Thank you. Fatima Akhtar Ruby says, great discussion. Mashukur Rahman, thank you, Ruby. Mashukur Rahman has another question about compartmental resection and commando operation.
Hello? I think another question from Dr. Pranay Bhattacharya is a good follower of me. He's a maxillofacial surgeon in West Bengal. What is the question?
I see. Hello, Pranay.
Hello, Pranay.
Okay. In case of maxillary carcinoma invading the anterior cheek skin, and if it involves the medial wall orbital floor, what will be the incision and reconstruction options, sir? With respect for sir from India. Thank you, Dr. Pranay.
Okay, in case of there is invading anterior cheek skin, and if it involves the medial wall orbital floor, what will be the incision? So in case of this type of lesion, you can do the Weber-Ferguson, and then the cheek skin also you have to remove. Then you can go through the excision and then reconstruction by the ALT. Okay, anything you can add, Manju?
Okay. And I think the lesion boundary, that is free margin boundary, it will also go to the medial wall of orbit. It can be done with the Weber-Ferguson approach, I think.
Weber-Ferguson and Lynch extension may you can give.
Lynch extension may be used.
Go for the Lynch extension.
Yes. And regarding the question of Mashukur Rahman, compartmental resection, he wants to know about compartmental resection.
Compartmental resection actually in case of muscle, they told that you have to resect the total muscle. Okay.
Yes, from the origin to insertion. If any part of the muscle is involved, then it is thought that the theory is that it has involved the total length of the muscle from origin to insertion.
That is the one principle. Another principle is in general cancer surgery, we go from anterior to the posterior. That is posterior part, we go the later. But in case of compartmental resection, theory is you go posterior first. That is the posterior first and then come forward. That is you already remove from the posterior. There is no residue behind. and
Yes.
the artery or vessel or nerve, you should go far away from the lesion. These are the basic things in the compartmental resection.
Yes.
If you
And
add,
Trimatric group, no, your answer is perfect. And commando operation, I think it was earlier term, and
yeah,
it is called combined mandibulo-oral resection.
mandibular
And
resection.
resection, but it is different from compartmental resection theory, I think. And Srimati Rubel wants to know about the indications of postoperative concurrent chemoradiation therapy.
In case of
When will give postoperative CPRT?
T2, T3, T4. Okay, so we will go for the in case of T3 and T4 lesion, that is stage 4 or stage 3 lesion, we can go for the resection and then for concurrent chemoradiation. But if the node is positive, we always suggest the concurrent chemoradiation. But if the node is not positive, then we go for the surgery and the radiotherapy. Okay. Manju? Hello.
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 I think the indications are it is about the postoperative histopathology status should be assessed properly. If the histopathology suggests that there are some adverse features like perineural invasion, lymphovascular invasion, and there is margin is involved in the resection, margin is not free from the tumor. In that case, we can go for CCRT. And another thing is what you have mentioned earlier, that more than one positive lymph node in the neck, as well as extranodal extension. Extranodal extension. It is these are the indications for postoperative concurrent chemoradiation therapy, I think.
Yes.
And Kamrul Hassan Shayer said that thank you, sir, for such informative and lively presentation. Thank you. Kartik Ball, very nice presentation. Thank you very much. And another question is from Mumtahina. In case of patient having 50 plus age, what about the success rate in our country?
50 plus age actually is not the factor. Age is not the indicator. Indicator is the staging. If patient comes in the late stage, outcome is not satisfactory, but you can see in my presentation, maximum people are in late stage. Some are T4B, some are T4A, some are T3. So if it is only T1 or T2, excellent result. Few patients, they are surviving 5 years more, 6 years more, even 7, 9 years, no problem. So age is not the factor.
Okay. Yes, comorbidity, sometimes severe comorbidity can be a factor regarding the management options, but age is not, I think.
I think
another question from
Pranoy.
Pranoy, yes. Dr. Pranoy said that any option for bony reconstruction for medial and orbital floor for the previous case to prevent postoperative ocular complications.
Yeah, of course. Here you can give the fibula. You can give the DCI flap, and even in the fibula you can incorporate the titanium mesh to support the orbital
floor.
Orbital floor to make the orbital floor you can use.
Yes. Thank you very much. We don't have any other questions, I think. Very nice. It was a very nice discussion. And I'd like to ask you another question, which is uh, for you. That
Oh my
what
God.
are the roles of general dental surgeons can play in the preventive as well as in the detection of oral cancer, as well as regular surveillance of treated patients. We, the maxillofacial surgeons, are treating oral cancer patients like large ablative surgery, reconstructive surgery. After that, patient receives radiotherapy, chemoradiation therapy, and what after that, the patients are in the community. They want to have regular dental checkup and regular follow-up. What our dental surgeons can play their role in this type of situation?
Okay, dental surgeon can play role in various situations. First of all, the diagnosis. Uh, uh, in my proposal is we should have arranged regular CPD program about the oral cancer or many things, because general dentist should understand the lesion, that is the lesion is malignant or benign or something, so they should have good idea about the malignancy, about the how they look like, what are the site, what are the commonest site, what may be the factors. Say in case of sharp teeth, there is a lesion in the tongue. We should wait after grinding of the tooth or after extraction of the tooth. Sometimes it looks very aggressive, but after extraction or after grinding, you can wait 2 or more weeks. If the lesion gone, that's okay. If the lesion present, then you should go for refer to the oral and maxillofacial surgeon for histopathology. So my message is that they have to. That's why I shared a few slides to the site of the lesion and how they looks like. So that is very important. And then the general dentist can sort out. Okay, this lesion is malignant or pre-malignant lesions, say for lichen planus or leukoplakia or something. So they should have a good knowledge about the oral diseases. That is number one. Number two is the how they can help the treated patient. So when they have the good idea about the lesion, so when the reconstructed lesion, even the skin, wait, few. So when there is a lesion in the, when there is a treated case, then they can say that, okay, that is reconstructed by skin or any flaps or something. So they have to differentiate it. Okay, there is the lesion in the flap or lesion in the normal mucosa. What is the cause? There is a friction or nothing. So another thing is the neck not palpable. That is neck examination. You have to competent about the neck examination. So he has to know. You look when you go for the when the patient receives the radiotherapy, and after a couple of months after radiotherapy, there is huge swelling in the submental region and other sides. So that is due to radiotherapy. So general dentist should know what are the effect of radiotherapy, what may happen, so they can sort out. They can check uh, the patient, and they can examine the neck. So I think by this way they can help the treated patient, and of course they have a
Yes,
role for prevention also. Okay, you can add
yes.
something.
I think I can add something that radiation carries another problem
Yes.
in our treated patients. Some early lesions can be detected by the general dentist, and some restorative work, such as filling and some endodontic work, can save the teeth
Yes.
of the
Yes.
patient. And
Yes.
sometimes the patients are neglected themselves, and they do not go to the dental surgeon for the regular checkup, and sometimes they come with very badly broken teeth which are by radiation carried. And in that case, the tooth extraction after radiation brings about the osteoradionecrosis. And I think this type of lesions can be largely preventable. Sometimes we have treated the uh, cancer, and cancer is cured, but the patient is suffering from osteoradionecrosis after 2, 3, 5 or 6 years after the successful surgery and successful radiation therapy. The patient suffers by the osteoradionecrosis. I think it can be prevented by early detection of the radiation carried by the dental surgeon and simple restorative work earlier. Thank you very much. And with that, I think we should conclude this session. And Abdullah Masood is one of the idol of young maxillofacial surgeons in the country. And I think our students and trainees of future generations will be inspired by his talk, and they will be inspired and to be one of the one Abdullah Masood in the future, I think. And thank you, Basic Dental School, for arranging such lively programs. And I think academic discussions was there, and everybody will be benefited. And dental surgeons, especially the young dental surgeons, and our undergraduate students will also be benefited from the talk, because sometimes our undergraduate students are not so confident enough. They feel frustrated to be here in the dental school or dental units and dental colleges. And I think the frustrations will be gone, because we are not only limited to the oral cavity or to the teeth. We are also looking to the fibula. We are working with the pectoralis major flaps. We are working with the microvascular flaps. And I think everybody will be inspired by your presentation. Thank you very much, Dr.
Thank
Abdullah
you.
Masood, and thank you, Basic Dental School, for arranging such lively programs.